Okay. It is bronchopulmonary dysplasia. Okay, this 4 weeks old preterm neonate likely has bronchopulmonary dysplasia or chronic lung disease of the prematurity. Bronchopulmonary dysplasia is diagnosed when a premature neonate continues to require supplemental oxygen more than 28 days. Signs of respiratory distress, tachypnea, retraction are often present. Previously, mm, previously before widespread use of antenatal steroid, previously before widespread use of antenatal steroid and neonatal surfactant, BPD was typically due to chronic ventilatory injury and oxygen toxicity and was characterized by fibrotic, scarred, and hyperinflated lungs. With regular use of non-invasive ventilation, BPD has evolved. Disease manifestation now primarily reflect arrest of pulmonary development, impaired alveolarization results in a reduced number and septation of the alveoli, and disrupted vasculogenesis causing dysmorphic and abnormally placed alveolar capillaries. Management of BPD includes nutritional support, fluid restriction, and avoidance of mechanical lung damage. Over months, new alveoli develop and pulmonary function can normalize. Do you want me to read the box? Okay. Okay. This patient has persistent asthma. Okay, can you explain me the previous question where it is written that uh, 28 he has been the baby has been taking oxygen for more than 28 days. They have already they in the question there is written that mechanical ventilation until age 5 days. So how it is BPD? he is just receiving oxygen still now. Okay, 4 weeks old boy. Okay, yes, okay. That's the thing I missed. Oximeter is 90. Okay. This patient has persistent asthma. This patient has persistent asthma diagnosed when any of the following criteria are present during the week: nocturnal awakening, nocturnal awakening with asthma. Hello, sorry. So this patient has persistent asthma diagnosed when any of the following criteria are present. Any of the following criteria are present during the week: nocturnal awakening with asthma on any night, nocturnal awakening with asthma on any night, often the earliest indicator of poor disease control, symptoms requiring reliever inhaler use on most days, and reduced FEV1 while the patient is taking bronchodilator therapy. Many patients may be falsely reassured their asthma. Many patients may be falsely reassured that their asthma is well controlled because their symptoms do not interfere with daily life and are alleviated with acute reliever therapy alone. Therefore, they may self-treat intermittently despite having persistent asthma, which leads to chronic under medication and poor long-term control. Under treatment of persistent asthma is associated with greater lung function, greater lung function decline, and a higher likelihood of severe acute exacerbation. Patient with persistent asthma should be treated with a scheduled combination inhaler that contains both inhaled corticosteroid and a long-acting fast onset beta agonist. Long-acting fast onset beta agonist formoterol preferred. Clinical response should be reassured using validated tools such as asthma control test questionnaire. If the asthma remains uncontrolled, persistent nocturnal awakens, the next step would be to increase the dose of the inhaled corticosteroid component. Okay. Sorry, maybe in the lung only. The main clue in here, like previous chest X-ray was normal, but now there is a lesion. If previous chest X-ray was uh, show this kind of lesion, then we do not need to do anything, no further testing. Okay, look at the flowchart. Solitary pulmonary nodule on chest X-ray. Previous chest X-ray, stable lesion over 2 to 3 years. Stable lesion over 2 to 3 years. No further testing is needed. No previous imaging or possible nodule growth. CT chest. CT chest. If benign feature, serial CT scan. If indeterminate or suspicious for malignancy. If indeterminate for or suspicious for malignancy, further investigation with biopsy or PET, like position emission tomography. Highly suspicious for malignancy, surgical excision. ASPN ASPN solitary pulmonary nodule is defined as a round opacity up to 3 centimeter, a round opacity up to 3 centimeter in diameter within and surrounded by pulmonary parenchyma. By convention, there must be no associated pleural effusion, adenopathy, atelectasis. SPN is often discovered incidentally on chest X-ray. SPN is often discovered incidentally on chest X-ray and can be due to many causes. The first step is to compare previous X-rays or scans and SPN with stable size and SPN with stable size appearance for an SPN with stable size and appearance for 2 to 3 years has high has low malignancy risk, and the patient may be given reassurance without further workup. Ground glass lesion have a higher malignancy risk. Ground glass lesion have a higher malignancy risk and likely require early assessment even with stable appearance and size. Unstable or new lesion require further assessment for malignancy risk. The main objective in assessing SPN is to promptly detect and surgically resect malignancy to leave benign lesions intact. Nodules less than 0.8 centimeter with smooth margin are less likely to be malignant, and nodules more than 2 centimeter irregular speculated margins are more likely to be malignant. Other factors to consider are age and smoking status. Patients aged more than 60 have a higher likelihood of malignancy. In addition, current smokers have increasing malignancy risk as the daily cigarette consumption increases. This patient has new SPN. This patient has new SPN since a previous chest X-ray requires chest CT scan to assess uh, chest CT scan to further assess the malignancy risk. CT scan is more sensitive than chest X-ray to identify these features and also detect other small nodules that may represent metastasis. If the CT scan findings are suspicious for malignancy, biopsy followed by likely surgical excision should be performed. Lesions that appear less likely to be malignant on CT scan can be followed with serial CT scan for 2 to 3 years to monitor for growth. Okay, system. Okay, in this patient, persistent cough, wheezing following a choking episode, finding concerning for foreign body aspiration. Typical presentation involves a young child, age 1 to 3, sudden onset cough after choking a food, seed, nut, or a small toy. Diminished breath sound, diminished breath sounds and or wheezing are often heard. Diminished breath sound and wheezing are often heard over the affected lung fields due to air trapping distal to the obstruction. Because of fixed bronchial obstruction, focal wheezing caused by foreign body aspiration. Focal wheezing caused by foreign body aspiration is generally not responsive to albuterol. However, particularly in patients with asthma, the foreign body may also trigger airway reactivity, diffuse wheezing that improves with albuterol, as seen in this patient. Chest X-ray findings suggestive of foreign body aspiration include unilateral lung hyperinflation with mediastinal shift to the affected mediastinal shift to the unaffected side. However, a normal radiograph does not rule out the foreign body aspiration because at least 30% of the radiographs are normal, if a radiolucent foreign body is lost in a small airway, and therefore if clinical suspicion remains high, bronchoscopy is indicated to confirm the diagnosis and remove the aspirated object. Okay. High cardiac index. Ca- Yes. Everywhere cardiac output is low, and like in cardiogenic shock, cardiac output is low, but in obstructive shock or mm, sorry, where normal or normal, yes. Systemic SVR is decreased. Sepsis looks like sepsis and a, say in sepsis there is no like cold extremity. Sepsis there is warm extremity. And third heart sound, yes. Sepsis, yes. No, the sepsis does not hurt. Pulsus paradoxus. In inspiration, BP falls. If it falls more than 10 millimeter of mercury, that is pulsus paradoxus. And the cause are P coat, uh, pul pulmonary embolism. Uh, sorry, looks like pulmonary embolism. Look here, auscultation show reduced breath sound, crackles, and there is hypotension, tachycardia. I don't know. I don't know. You give your answer. Uh, wait, it is septic shock. You are right. No, in septic shock, warm extremity. I know that. I know it very well because in the early days, I remember only one thing, like warm extremity has all the shocks and the sorry, warm extremity is septic shock and cold extremity is all the shocks. Warm, like think about a bacteria is inside your body, so it will make your body warm, and other shocks will make your body cold. Okay. Yes, I missed it. That's my problem. When I like, sorry, my problem is if one thing goes in my head, it does not easily comes out. Like when I read all the question, then I thought it is pulmonary embolism, and I failed to actually exclude all the options. Like I am unable to find the relation between bounding pulse. I know that sepsis may cause bounding, like due to hyperdynamic circulation may cause a bounding pulse. Okay. Okay, that's good. That's a good way of excluding. Yes, yes. Okay. This patient, this patient with likely pneumonia, reduced breath sound and crackles in the right lung as signs of septic shock, including hypotension and tachycardia. Patient with septic shock, patient with septic shock develop hypotension from peripheral vasodilatation, which leads to decreased systemic vascular resistance and capillary leak with loss of intravascular volume into the surrounding tissue, which leads to borderline low atrial pressure and pulmonary capillary wedge pressure. To compensate for intravascular hypovolemia, the cardiac index and the stroke volume increase, leading to increased pulse pressure, systolic minus diastolic pressure, which can manifest as bounding pulse. The finding of bounding peripheral pulses is seen. The finding of a bounding peripheral pulse is seen in early phase of sepsis, known as hyperdynamic phase. Without treatment, this can progress to more severe hypodynamic phase, with patients developing cool and clammy extremity due to decreased blood supply as blood is preferentially shunted to the vital organs. This phase is associated this phase is associated with decreased cardiac output and increased systemic vascular resistance. Okay. Airway hyperactivity is asthma. It's first generation antihistamine. None of them. Yes. I think antihistamine actually decreases the nasal secretion, and it looks like nasal problem. He has chronic rhinorrhea. So rhinosinusitis may be the cause of his cough. Okay. Okay. The three most common cause of chronic cough more than 8 weeks are upper airway cough syndrome, post nasal drip, asthma, and GERD. Upper airway cough syndrome is caused by rhinosinus condition include allergic perennial, non-allergic, and wastewater rhinitis, acute nasopharyngitis, and sinusitis. Cough is caused by mechanical stimulation. Cough is caused by mechanical stimulation of the afferent limb of the cough reflex in the upper airway. In this condition, based on her history, the patient's dry cough is most likely due to post-nasal drip associated with allergic rhinitis. The diagnosis is confirmed by improvement of nasal discharge and cough with the use of first generation antihistamine. Chlorpheniramine, a type of H1 antihistaminic receptor blocker that reduces the action of the histamine H1 receptor, decreasing allergic response. In addition to in addition to blocking H1 histamine receptor, chlorpheniramine exhibits anti-inflammatory effect by blocking histamine release from the mast cell, limiting the secretory response to inflammatory cytokines. Okay, yes, asthma can cause chronic cough. It is caused by variable and recurring symptoms, airflow obstruction, bronchial inflammation, and airway hyperreactivity. Airflow obstruction, bronchial inflammation, and airway hyperreactivity. Empiric treatment involves inhaled corticosteroid, which reduce airway inflammation, and beta agonist, which dilates the bronchial smooth muscle. Antihistamine have no role in asthma management. Okay, about 5 to 20%, about 5 to 20% patients treated with angiotensin converting enzyme inhibitor develop dry cough due to AC inhibition, causing decreased degradation of the bradykinin and the substance P. Accumulation of these substances causes chronic cough. Cough improves only with discontinuation of AC inhibitor, not with antihistamine. Okay. Okay. Think in easiest way. You are on the right track. Okay. Sorry. But there is a traveling history. Like not everybody is that full, like doing a PCI and then start flying to different countries, like our cricketers. I have I have searched plenty of thing about this. Like after doing PCI in the AI, they told to at least uh, wait for a week for flying. Like because anytime PE can happen. Pulmonary embolism is a wonderful thing. It can happen at any time. Look at this patient has sudden severe chest pain for no reason. Okay, so this patient's presentation, pleuritic chest pain in the setting of long distance flight. This patient's presentation, pleuritic chest pain in the setting of long distance flight, hemoptysis, dyspnea, tachypnea, tachycardia, and OCP use is concerning for pulmonary embolism, although 10% patients with PE have an occlusion of the peripheral artery by thrombus causing pulmonary infarction. So 10% patients with PE have 10% patients with PE have occlusion of the pulmonary artery by thrombus causing pulmonary infarction. These small these small peripheral thrombi are more likely to cause pleuritic chest pain and hemoptysis due to inflammation and irritation of the lung parenchyma and adjacent visceral and parietal pleura. These patients have several risk factors for acute PE requires diagnostic testing. CT pulmonary angiography is typically used for diagnosis in most patients. Dumbness to percussion on right lower lobe. Pneumothorax. There is two things present, like percussion note is dull and breath sound are increased. Breath sound is increased only one condition. Yes, pneumonia can have because in pleural effusion breath sound is diminished or absent. And in interstitial lung disease there may be fine crackles, velcro, fine inspiratory crackles. And mm, in emphysema, like there is, what can I say? Vesicular with prolonged expiration. That sound okay. Looks like pneumonia. Looks like yes. Okay, this patient with shortness of breath, cough, dullness to percussion, and increased breath sound over the right lower lung, likely has lobar pneumonia causing focal or lung consolidation. A normal lung is resonant to percussion, and auscultation at the periphery demonstrate vesicular breath sound that consists of a quiet inspiratory phase and an almost inaudible expiratory phase. When a portion of the lung is consolidated, that is a lobar pneumonia, the density of the tissue or fluid increases and a dullness to percussion is detected. In addition, sound conducts more rapidly and efficiently through the consolidated lung, resulting in increased intensity of breath sound and a more prominent expiratory component. More rapid and efficient More rapid and efficient sound conduction also results in increased tactile tremulous vibration generated by air movement in the lung, as well as egophony, sounds like the letter A when the patient says the letter E in an in areas of lung consolidation. Crackles are also often heard. Okay, yes. Mucus plugging decreases airflow in the affected part of the bronchial tree. In the collapse of the downstream lung parenchyma, breath sound will be absent in the affected area. She recently returned from a trip. I think so. It is PE. May not be PE. Yes, the one is barrier contraception. Another thing to rule out the PE, like D dimer is normal. All the labs are normal. According to modified Wells criteria, it is zero. I think so. It is less likely PE. One, yeah, 3 point like how maybe. Okay, we need to look at how many points he got. Okay, his modified well criteria is zero. Written in the explanation I am reading. Wait. This patient has self-resolving dyspnea with no chest pain, or with no chest pain or fever, unremarkable labs, radiology study, possibly due to underlying anxiety. Her normal chest X-ray exclude pulmonary edema or pneumonia. Pulmonary embolism is on the differential due to the variability of the pulmonary embolism. The modified Wells criteria can help to distinguish. So what are the signs? Look at the modified Wells criteria. Clinical signs of DVT, alternate diagnosis less likely than PE. Got 3 point. Previous PE or DVT got 1.5. Heart rate and recent surgery or immobilization got 1.5 point. 1 point for hemoptysis and cancer. If it is less than 4, then PE unlikely, more than 4, PE likely. Okay. It can help assess in pretest probability, long distance flight. Although a risk factor for VTE, venous thromboembolism, does not qualify as immobilization, per Wells criteria. Therefore, these patients' modified Wells score is 0. This result gives an unlikely pretest probability for PE, and her normal D-dimer result effectively rules out PE. D-dimer has 95 to 97% sensitivity and 45% specificity for VT, venous thromboembolism. The positive predictive value PPP and negative predictive value are dependent on the pretest probability, disease prevalence, individual pretest probability in patients with unlikely probability of the venous thromboembolism. D-dimer has a negative uh, D-dimer has a negative predictor value more than 95%. So a normal result less than 500 reliably excludes venous thromboembolism in patients with likely probability of the venous thromboembolism. The prevalence of the VTE is higher and lowering the negative predictive value and rendering a normal D-dimer result unreliable in excluding venous thromboembolism. No low negative predictive value or more false negative. In such patients, CT angiogram or a ventilation perfusion scan should be used to reliably exclude PE. Regardless of pretest probability, an elevated D-dimer has poor positive pressure ventilation and is not diagnostic of the venous thromboembolism. Okay. Is ESP pulmonary thromboembolism? What does? Sorry, it's a PE day. Oh, he is on intubation. He's still on intubation and fever is high. Oh, it's not PE. Okay. This intubated patient has increased respiratory secretion. Can you hear me? Okay. This intubated patient has increased respiratory secretion, worsening oxygenation, fever, tachycardia, new pulmonary infiltrate on chest X-ray, raising strong suspicion for VAP, ventilator-assisted pneumonia, a type of hospital-acquired pneumonia that occurs more than 48 hours after intubation. Most cases arise due to aspiration of the oropharyngeal gastric secretion. VAP is usually suspected when an intubated patient develops several of the following: new pulmonary infiltrate, new pulmonary infiltrate, increased respiratory secretion, new pulmonary infiltrate, increased respiratory secretion, and signs of respiratory status such as worsening signs of respiratory status such as worsening oxygenation, lower tidal volume, worsening oxygenation, lower tidal volume, and increase in respiratory pressure. Systemic signs of infection like such as fever, leukocytosis, and tachycardia. However, no constellation of manifestation conclusively proves VAP. Intubated patients often have pulmonary infiltrate on X-ray in the absence of VAP. Therefore, non-invasive endotracheal aspiration or invasive bronchodilator lavage, bronchovascular lavage, or sampling of the lower respiratory tract is required for confirmation. Moderate or heavy growth, moderate or heavy growth of one or more than one microorganism is generally diagnostic. Okay. What is your diagnosis? Yes, it is an RDS. Look at the X-ray or ground glass appearance on bilateral lung fields. In the next X-ray, in this X-ray, I do not know. It's not typical ground glass. Okay, okay. First box, neonatal cyanosis, distal extremities and lips, and normal SpO2 distal extremities and lips, and normal SpO2 peripheral cyanosis reassurance should be done. And mucosal or diffuse low SpO2, mucosal or diffuse low SpO2, central cyanosis, administer oxygen, central cyanosis, administer oxygen. If SpO2 is increased, that is pulmonary pathology, provide respiratory support, intubation, ventilation. If SpO2 is unchanged, if SpO2 is unchanged or hemodynamic instability, cardiac pathology and administer prostaglandin. Cardiac pathology and administer prostaglandin. Okay. Oh, sorry, explanation. This this neonate with central cyanosis involving lips mucous membrane has significant improvement of hypoxia with administration of oxygen, making primary pulmonary pathology most likely. In this case, increased work of breathing, retraction, decreased breath sounds, and bilateral ground glass opacities on chest X-ray are consistent with NRDS, neonatal respiratory distress syndrome. RDS is a condition in which immature and or inadequate surfactant production results in alveolar collapse and diffuse atelectasis. The greater risk for RDS is prematurity. However, poorly controlled gestational diabetes also increase the risk by delaying the normal maturation of the surfactant. Maternal hyperglycemia causes fetal hyperglycemia and in turn fetal hyperinsulinism. High levels of insulin antagonize cortisol, which results in delay maturation of the phosphatidylcholine, phosphatidylglycerol, vital phospholipid components of surfactant. RDS management include respiratory support, continuous positive airway pressure to provide positive end expiratory pressure, and exogenous surfactant. Surfactant decreases alveolar surface tension, which increases compliance and prevents collapse and improve lung expansion. Endogenous surfactant production after birth typically results in symptoms improvement within a week. Okay. It's respiratory acidosis, isn't it? Is it myasthenia gravis? Is it myasthenic crisis, infection, pneumonia? Apart from these, nothing fits. What we will do in myasthenic crisis? Intubation. Patient is hemodynamically stable. BP 130. No, myasthenic crisis, I guess. But okay, okay, yes, okay. This patient with myasthenic crisis. This patient with myasthenic crisis has an community acquired pneumonia, fever, leukocytosis, focal opacity, and possibly related to aspiration right lower lobe. In addition to valvar weakness, dysphagia, drooling, she has developed generalized weakness affecting respiratory muscles, diaphragm, signified by respiratory acidosis, hyperinflated lung, rapidly worsening weakness with respiratory involvement is consistent with myasthenic crisis. Myasthenic crisis, these this life-threatening exacerbation of the myasthenia gravis can be precipitated by acute illness pneumonia. Myasthenic crisis is often under-recognized due to inability to recruit recruit enhanced accessory muscle, no retraction or visible effort. Patient may be approaching respiratory arrest before any overt distress is apparent. Management includes hospital admission, close monitoring of respiratory muscle function, falling vital capacity. Treatment is plasma exchange and corticosteroid requires several days to produce clinical improvement. Therefore, elective intubation should be discussed when impending respiratory failure is present, such as these patient shallow respiration and hypercapnia. Intubation protects the airway, further um, prevents further aspiration and allows mechanical ventilation to be provided until the respiratory muscle recover. Elective intubation secures the airway in a controlled fashion versus urgent crash intubation. Non-invasive ventilation may be contraindicated due to drooling and inability to clear suction. Weak cough. Okay, yes. In the absence of myasthenia gravis, this patient could be treated at home with oral antibiotics. However, she has an impending respiratory failure due to myasthenic crisis, which requires stabilization in the hospital, stabilization in the hospital. Blood pressure may be indicated to tailor antibiotic therapy, but fluoroquinolone are known to be exacerbate myasthenia gravis by blocking neuromuscular transmission should be avoided. Pyridostigmine is sometimes used to treat mild MG exacerbation, but it is not effective for severe disease with respiratory impairment due to the potential for increased secretion, increased cholinergic activity is typically discontinued in patients with impending respiratory failure. Atropine blocks acetylcholine and pralidoxime restore acetylcholine storage activity are used to treat the cholinergic crisis which can develop in patients with MG who receive supratherapeutic doses of acetylcholinesterase inhibitor. Both myasthenia gravis and cholinergic crisis feature diffuse weakness and drooling of the bulbar function in myasthenic crisis. Hypersalivation, hypersalivation in cholinergic crisis, but the cholinergic toxidrome has also involved meiosis, bradycardia, which are present, which are absent in this patient. Okay. Looks like PE. Today I will diagnose PE or will take heparin. So as his GFR is very low, so we cannot give, yes, normal GFR is 90, probably 90 ml per minute per 1.73 meters. Lots of things we cannot give, like we cannot give direct, like oral anticoagulant. We cannot give low molecular weight. Even we cannot give fondaparinux. We can give other two. Yes, maybe it may be the answer. We can give warfarin too, but it is the first, like before giving warfarin, we need to do the bridging. So what we will choose in pregnancy, enoxaparin can be given. Pregnancy, low molecular weight heparin is safe. Like Think about in that way, like antiphospholipid antibody syndrome. They have a pregnancy, so they can give enoxaparin. Okay, it is unfractionized heparin. Okay, this patient has confirmed pulmonary embolism. Untreated PE has most likely, untreated pulmonary embolism has a mortality risk up to 30% due to recurrent pulmonary embolism, recurrent embolism. As a result, immediate anticoagulation is required unless contraindicated. There are many anticoagulant options available: low molecular weight fondaparinux, low molecular weight like enoxaparin, fondaparinux like 10A inhibitor, and rivaroxaban like oral factor 10A inhibitor. Cannot be used in patient with severe renal insufficiency. Estimated GFR is less than 30 ml per minute per 1.73 meters square. As reduced renal clearance increase anti-10A activity leads anti-10A activity level and bleeding risk. Okay, non-fractionized heparin is recommended in patient with decreased estimated GFR rate. Decreased estimated GFR rate as it is more convenient to monitor its therapeutic level via activated PTT. Once the heparin produces its therapeutic anticoagulation goal, PTT 1.5 or 2 times normal, warfarin is initiated. Warfarin can take up to 5 to 7 days. Warfarin can take up to 5 to 7 days to reach the therapeutic level. It also inhibits protein C and S. Antithrombogenic proteins can be protein C or S and can be thrombogenic without a second anticoagulant heparin as a bridge after reaching therapeutic INR. Heparin can be stopped and warfarin can be continued long term. Okay. Rivaroxaban is an oral anticoagulant with immediate onset of action, unlike warfarin. Therefore, no bridging with heparin is indicated. Unfortunately, this is not an option for patients with severe renal insufficiency. Yes, and we are going to switch to warfarin. Warfarin can be given for long term, even if he has kidney issues. He may have a like, is it exudative pleural effusion? Because according to Light's criteria, pleural fluid protein by serum protein, pleural fluid LDH by serum LDH, and mm, serum LDH is two-thirds of the upper limit of the. I only one criteria is present, and thoracosynthesis. Okay, we do not know the thoracosynthesis level. Okay. Mm, Hepatojugular reflex is present. Hepatojugular reflex for cardiac issue. Cardiac is hepatojugular reflex comes with cardiac issue, isn't it? And cardiac CCS has exudative transfusion, exudative pleural fluid, and exudative. How am I? Sorry, transudative. Transudative. Sorry. CCF cirrhosis, nephrotic syndrome. Then and transudative pleural effusion has what kind of scenario? Okay, you are right. I it's transudative pleural effusion. Okay, look at the second para first. Normal pleural fluid. Normal pleural fluid pH. Normal pleural fluid pH is approximately 7.60. Normal pleural fluid is approximately 7.60. Transudative is usually due to systemic factor, increased hydrostatic pressure and hypoalbuminemia, increased hydrostatic pressure and or hypoalbuminemia, and has a pleural fluid 7.4 to 7.55. Exudative has pleural fluid 7.3 to 7.45, 7.30 to 7.45. Okay, if pleural fluid pH is less than 7.30, it is usually due to increased acid production by pleural fluid cells and the bacteria like empyema, or decreased hydrogen decreased hydrogen efflux from the pleural space. Decreased hydrogen efflux from the pleural space, pleuritis, tumor, and pleural fibrosis. Okay. This patient's presentation is consistent with congestive heart failure. Congestive heart failure commonly Congestive heart failure commonly causes transudative effusion. Transudative effusion, however, 25% of the effusion can meet exudative criteria if the patient has received aggressive diuretics prior to thoracosynthesis. These effusions are usually bilateral 61%, but can be unilateral on either right or left side. The elevated pressure from the left ventricular end diastole and the left atrium transit back to the alveolar capillaries to hydrostatic pressure. This leads to fluid movement across the visceral pleura to the pleural space. Light's criteria can distinguish transudative from exudative. Pleural fluid protein by serum protein more than zero point 0.5, pleural fluid LDH by serum LDH more than zero point 0.6, and pleural fluid LDH two-thirds of the upper limit of the serum normal LDH. Okay, yes. Transudative, I remember like CCF, cirrhosis nephrotic syndrome, and after C, there is D like dialysis. So CCF, cirrhosis, nephrotic syndrome, and dialysis. And exudative, mainly the infections, inflammations, malignancy, connective tissue disease, CABG, and my favorite, pulmonary embolism, and movement of fluid from abdomen to pleural space. Okay. Yes. Pleural fluid LDH 210 would be pleural would be given a pleural by serum LDH more than pleural by serum LDH more than zero point 0.6. Pleural fluid protein is 5 would give a pleural or serum protein more than zero point 0.5, both of which found in exudative effusion, which is less likely in this patient with new onset and untreated CHF. Is it asthma? Okay, it's acute, sorry, inhaled bronchodilator. It's not like upper airway cough syndrome. Like patient has acute upper respiratory tract infection, but no nasal congestion or rhinorrhea, so not antihistamine. Okay, and you, yes, okay, it's acute bronchitis, another confusing disease. Okay, okay, usually the same. Yes, acute bronchitis and emphysema. I got it. Because, but that chronic bronchitis have a certain criteria, like cough for more than 3 months, for a year, for at least 2 years, for chronic bronchitis. Yes, yes, yes. That's why. So after respiratory tract infection, if like cough syndrome, then we will think about bronchitis. And after like like respiratory tract infection like rhinosinusitis along with nasal congestion, that is upper airway cough syndrome, where first generation antihistamine works well, like chlorpheniramine. The previous one of the question. Okay. So this patient has persistent dry cough following upper respiratory infection. He has mild wheezing on examination. He has mild wheezing on examination, but the clinical findings are otherwise unremarkable. This patient's presentation is consistent with acute bronchitis. Acute bronchitis is a self-limited infection that can last for 3 to 4 weeks. Most More than 90% cases are caused by viruses, rhino, corona, influenza. Purulent yellow or green sputum can occur. Purulent yellow and green sputum can occur due to epithelial sloughing and is not a sign of bacterial infection. Patients may also mild Patient may have also mild dyspnea, chest wall discomfort from coughing, crackles from airway secretion may be audible but typically clear with cough. Unlike pneumonia, fever is not typical and should raise suspicion for bacterial pneumonia. Treatment of acute bronchitis is primarily supportive and may include throat lozenges and over-the-counter suppression, dextromethorphan or guanfacine. Patients with associated wheezing in the setting of pulmonary setting in the setting of underlying pulmonary disease, asthma, may benefit with inhaled bronchodilator like albuterol. Otherwise, these medications are not generally recommended. Oral corticosteroids are not indicated. Next. Yes, chronic bronchitis is cough more than 3 months in a year for at least 2 years for chronic bronchitis to happen. Like upper airway cough syndrome. In upper airway cough syndrome, cough for more than 4 to 8 weeks. In upper airway cough syndrome, there may be rhinosinusitis along with nasal secretion, where we will give the first generation antihistamine. Because look here, in like first generation antihistamine, like option E, look at the option E. First generation antihistamine are useful in combination with nasal congestant for upper airway respiratory syndrome, like upper airway cough syndrome. Although they are associated with significant side effect, sedation, first generation, second generation, actually loratadine alone are less effective for upper airway symptoms and are not indicated for acute bronchitis. So for upper airway cough syndrome, we will give first generation antihistamine. Yes, that would be like rhinosinusitis. Yes. Look at the question 29. Look at the upper airway cough syndrome. There is three differential like PND, postnasal dripping, and asthma and GERD. And upper airway cough syndrome is associated with rhinosinus uh, and a cough and a nasal problem. Okay, got it. Yes, it is also called like postnasal drip, or you can say it simply like upper airway cough syndrome. These are the very confusing things. Or asthma, yes, got it. Pink puffer and blue blotter, but that happens in chronic bronchitis. Problem starts after taking antibiotics, and he has an arterial rash. Looks like anaphylaxis. So this patient with skin findings, arterial rash, respiratory difficulty, wheezing, hypertension, and has anaphylaxis caused by antibiotic exposure. Diagnosing anaphylaxis can be challenging if symptoms are initially attributed to a pre-existing medical condition, asthma, as happened with the patient. Epinephrine is most important treatment for anaphylaxis. It has alpha and beta agonist effects that quickly cause vasoconstriction and increasing blood pressure, bronchodilation, and improving wheezing. Epinephrine also decreases further systemic release of the inflammatory mediator from mast cell and basophil, halting anaphylaxis. Intramuscular injection performed rapidly and is the preferred route of administration, can be repeated every 5 to 15 minutes up to 3 doses if symptom persists. If anaphylaxis does not respond to several rounds of epinephrine, IV epinephrine infusion would be necessary. Epinephrine is not administered via route via this route due to higher risk of dosing error and cardiac complication, arrhythmia. Okay. B. Endotracheal intubation is performed when prominent upper airway edema, oropharyngeal swelling, stridor, stridor is present in anaphylaxis. It does not directly address lower airway bronchospasm, the source of patient's respiratory distress. In contrast, rapid epinephrine administration may improve bronchospasm and prevent progression to respiratory failure. In addition, positive pressure ventilation, mechanical ventilation decreases venous return to the heart and can cause cardiovascular collapse in a hypertensive patient unless hemodynamic support epinephrine is underway. Okay, yes, okay. This is ARDS. This patient likely has ARDS due to pancreatitis. ARDS presents clinically as dyspnea, tachypnea, significant hypoxemia, and bilateral alveolar infiltrate on chest X-ray, all developing within a week of clinical insult. Pancreatitis, mechanical ventilation is often required to support patient's lung. The goal of the mechanical ventilation is ARDS is to provide adequate oxygenation and ventilation without causing further injury to the lungs. This is accomplished by using lung protective strategies such as low tidal volume ventilation. Ideal volume is 4 to 6 ml per kg of ideal body weight. In ARDS, significant number of the alveoli remain collapsed despite positive airway pressure, and any tidal volume delivered by the ventilator is distributed to those remaining open functional baby lung. In low tidal volume, ventilation prevents overdistension of the alveoli compared to use of higher tidal volume more than 8 ml per kg. Low tidal volume ventilation prevents overdistension of the alveoli compared to higher tidal volume. Low tidal volume improves mortality in patients with ARDS. Number needed to treat 11. High tidal volume, excessive stretching of the damaged and delicate alveoli to further compounded the lung injury. Okay. Yes, neuromuscular blocking drugs, cisatracurium, are useful in promoting patient ventilator synchrony to improve gas exchange and reduced barotrauma, as well as minimizing oxygen consumption by skeletal muscle. Neither of adverse effect nor of benefit of this agent has been established regarding patient mortality. And in normal supine position, ventilation is already high in the ventral lung region and further increase causes alveolar overdistension. Prone positioning distributes the ventilation from the ventral to dorsal dependent lung regions where the majority of the alveoli are located. This improves the homogeneity of the ventilated through the lungs and decrease mortality in patients with ARDS. Okay.